OCD, Obsessive Compulsive Disorder. Obsessions are defined as recurrent and persistent thoughts, urges, or images that are experienced as intrusive and unwanted at some point and cause anxiety or distress. Also, the individual has to have attempted to ignore or suppress such thoughts, urges, or images, or neutralize them with some other thought or action. Compulsions are the need to perform repetitive behaviors or mental acts in response to these obsessions. The behaviors or acts are meant to prevent something bad from happening or to decrease the stress of the sufferer. The behaviors or acts are excessive and do not realistically relate to what the person is trying to prevent or neutralize. OCD is diagnosed by four basic criteria. First is the presence of either obsessions or compulsions or both, which were defined in the last slide. The second is if the compulsion or obsession is considered time-consuming, for example, lasting more than an hour, or detracting from social, occupational, or other important functions. The third is that the symptoms displayed aren't due to the physiological effects of a substance like a drug or medication, or another medical condition. The fourth is that the symptoms of the experience aren't closer to those of another disorder. In the DSM-5, many different disorders are associated with OCD, including body dysmorphic disorder, hoarding disorder, trichotillomania, and excoriation. Body dysmorphic disorder is characterized by the preoccupation with perceived defects in their physical self that aren't apparent to others and their repetitive behaviors in response to these appearance concerns. Hoarding disorder is characterized by persistent difficulty discarding or parting with possessions regardless of their value. Trichotillomania is characterized by the recurrent pulling out of one's hair resulting hair loss, along with repeated attempts to decrease or stop this hair pulling. Excoriation is characterized by the recurrent picking of one's skin with repeated attempts to decrease or stop it. During our research, we found several connections we could make to the textbook. OCD has several explanations by different perspectives of psychology, including behaviorist and cognitive, which we learned about in Chapter 1. The behavioral theory claims that OCD is caused when people associate certain situations or objects with fear, causing an obsessive or compulsive reaction to a trigger. The cognitive theory claims that people with OCD misinterpret their thoughts. Cognitive psychologists believe that everybody experiences intrusive thoughts, but people with OCD inflate the importance of these intrusive thoughts. The repetition of this process turns it into an obsession. OCD is actually considered a biological disorder, however, due to all the neurotransmission that occurs. When someone with OCD is shown or experiencing what causes their obsessions or compulsions, a neuromodulator called clomipramine is released. Clomipramine inhibits serotonin reuptake, like SSRIs, and norepinephrine reuptake, which we learned about in Chapter 2. OCD is also passed on through genes. Twin studies and familial studies, like the ones we learned about in Chapter 2, have been conducted and have proven that OCD is quite genetic. Now let's take a look at the case study. Karen Rusa is a 30-year-old with a husband and 4 kids. She has had anxiety for several years leading up to her compulsive behaviors. She had repetitive thoughts regarding her children's safety. She imagined horrible accidents occurring at school, and one day imagined her son Alan had broken his leg during football practice. Even after reassurance that he was okay, she was still surprised that he came home uninjured. She engaged in compulsive behaviors, including a counting ritual that prohibited her from buying certain items on the shelf, since she believed the order of the items corresponded with each of her kids and could result in harm to them. Her husband did not want to help discipline the kids or participate in other household regulations, so Karen became unhappy with her marriage, but she stayed for the sake of her children. When her husband got ill and started to stay home, she became depressed. Her past also played a role in her OCD. During her first pregnancy, she witnessed an infant getting seriously injured after another kid ran over him. This resulted in repetitive, intrusive thoughts about injury and self-harm. She was raised Roman Catholic with church rituals and harsh consequences for wrongdoings. Her mother also implemented strict schedules and severe punishments. This caused her a disillusion about the church. As for treatment, she sought out therapy. Cognitive therapy uses the approach of finding the underlying meanings that a person assigns to their intrusive thoughts and behaviors. She realized that the counting rituals and compulsions were acted as an attempt to control her life. These rituals replaced socially acceptable ones, such as practicing religion. She met with a local priest where she learned about changes made in regards to the church's way of teaching. She accepted the rationale and renewed her interest with religion. She developed interpersonal skills and reconnected with her family. She was afraid, however, that she would be rejected if she asserted herself, so she stayed passive and was often unhappy with her family's behaviors. After steady progress for 3 months, she was able to terminate therapy after making positive changes in her life, such as stopping her counting rituals, communicating better with her family, renewing her interest with the church, and no longer suffering from depression. Thank you.